Right. This will probably be the first session of invasive hemodynamics. I will present introductory session to invasive hemodynamics, and I think Dr. Awad Al-Ni'ma will take it from here because he had a presentation of invasive hemodynamics that cover all of it actually. Invasive hemodynamics is important for one basic reason, that it teaches you a lot about the physiology of the heart. You remember the session of Jamil of loops, volume pressure loops? It was so educational as to the physiology and the actions of the heart, the relaxation, contraction, pressures, and all of that. Now this goes along the same line. Now, if I ask you, do you think that invasive hemodynamics is obsolete? Do you think it's obsolete? Well, it has a place in cardiology.
I think still it has a place, Boss. It could never be obsolete. Even there is a lot of advances, but still it will be, and it has a place always.
Exactly. But if we compare it with the history, historically, invasive hemodynamics was all of the hemodynamics in cardiology were actually obtained invasively. But now we could say that invasive hemodynamics is just fallback option. The option that you recourse to in case you fail to answer your questions non-invasively. And how common is that? Not really common. And I remember no more than a handful of cases throughout 13 years of my cardiology practice that we needed cash to sort out disputes. And non-invasive hemodynamics has taken over almost exclusively. But we still, even in the guidelines, we have cash-based hemodynamics in case non-invasive hemodynamics were not adequate to answer your questions. You can go for invasive hemodynamics. If I take the first slide, this one, what do you think this catheter is doing? What's the name of this catheter? Any idea?
Trying to get the wedge pressure. This is the Swan pressure catheter.
Exactly. Thank you, Fikri. Thank you so much. So this is the Swan Gas Catheter. And Swan Gas Catheter traces the pressure from the right atrium to the wedge, passing through the RV and the pulmonary artery. So you will have four tracing like this one: right atrial pressure tracing, right ventricular pressure tracing, pulmonary artery tracing, and wedge. Okay, so it gives you ample, wealthy information. Okay, and how you advance it? You advance it just blindly. Okay, you go from the right side and you push, you advance until you wedge. How do you know you are wedging? How do you know you are wedging?
If I have the tracing of the pulmonary artery, the dichromatic
ركشة
of the pulmonary artery tracing.
داخلة جوا جنب المدارس.
The dichromatic notch in the tracing. It will,
okay, good.
It will what we call this? It will present the closure of the valve, and then it will. I will be sort of. I think so. That's
very good. This is one thing. The waveform itself should be of wedge, not of pulmonary artery. So if you have the waveform of pulmonary artery, you are not probably wedging. The other most objective way of assessing the proper the idealism of wedging is to obtain a sample for saturation, to check the saturation there. Okay, because in the pulmonary artery saturation is not as high as in the wedge. Wedge tends to be more than 97, 98. Okay, so make sure that you are wedging properly. And these are the waveforms along the wedge, along the Swan Gas Catheter. Okay. Now, if we take this slide, it represents the hemodynamics of the LV, the aorta, and the left atrium. Okay. You see the aortic waveform. You see it on top. It coincides with the peak of systole of the LV because there is no gradient. But if you have aortic stenosis, things will be different. Notice the difference in diastolic pressure between the LV and the aorta. The diastolic pressure of the aorta is much higher than the diastolic pressure of the LV. That's why it hands up. Okay, it hands up. The difference in diastole is big deal, but there should be no difference in systole. Okay, and the left atrial pressure, it has the A, X, V, and Y tracing, as I'm going to show you shortly. Now, what is this here? If we take wedge pressure and we compare it to left arterial pressure, what's the difference between the two? Any difference? Mm. Look, you can answer from the tracing here. This is left atrial pressure tracing and wedge tracing for the same patient. You see, there is probably no much difference in the
baseline.
figures, in the figures obtained. The mean pressure, the peak pressure might be equal, but the difference is in timing. You see, the wedge comes late, right? It comes late. So the wedge is not simultaneous like the LA pressure. And why it's not simultaneous? Because it reflects the LA pressure, and that takes time for the LA pressure to reach your catheter hanging up in the pulmonary. Okay, so that time makes a lot of diagnostic problem, which I'm going to show you in a bit. But remember, the wedge is not simultaneous. The LA pressure is simultaneous. So there is time delay. There is time delay. Like in terms of the calculation, the wedge is faring approximately so close to the LA pressure. But the problem with LA pressure, people don't like to obtain LA pressure because it's more invasive than the wedge. LA pressure entails piercing the septum and going from right to left, and that's not good. If you can wedge, it's better. But you have to know the limitation of the wedge. Okay, now look at this slide, which again is so important. In A, we have central ascending aorta tracing and femoral artery tracing. What's the difference between the two? It's for the same patient. It's for the same patient. You see that if you count it in terms of gradient, which one is higher? The one on the left or the one on the right? I mean the difference in pressure between the LV and the aorta. Which one is higher? On the left or on the right?
The one on the left, the aorta.
The one on the left, exactly.
Yes.
The one on the left is higher pressure than the one on the right.
Yes.
So if I want to calculate the aortic valve gradient, I'm searching for how much of aortic stenosis I do have. I can use central catheter or femoral catheter. But the femoral catheter is going to underestimate or overestimate the gradient.
Underestimate the gradient.
Underestimate.
Very good. And that is why?
Because of the distance of the blood going out.
Because?
The blood is going away from the valve area. Should be calculated.
Okay, you are so close.
Okay, the gradient should be near the area of stenosis. So whenever you go away, it gives you underestimation.
Yes. And why is that? Why is that? The further you go from the source of stenosis, I mean,
It
the
is
further
due
you go
to
from the
peripheral
aorta,
resistance, the high peripheral resistance.
high peripheral resistance will lead to, yes,
higher pressure.
higher pressure. Exactly. The lower you go, the higher the arterial pressure. That is called peripheral augmentation. I'm going to explain that. The peripheral augmentation leads to higher blood pressure as you go down. If you have higher systolic blood pressure, so when you compare the peak to peak, you will see that femoral versus central aortic will be different. And that will be underestimation if you are using femoral artery catheter. It will be underestimation. Okay?
Okay.
So you always have to use a central aortic catheter. But sometimes it can be overestimation. Yani if you use a femoral catheter, it might lead to overestimation sometimes.
Yes,
Do you
sclerotic
have
patient.
any? Exactly. If you have aortic femoral artery stenosis and you are checking there, the pressure will be lower than it should. So in this case, you are overestimating. Okay? So the femoral artery mostly leads to underestimation, but it can well lead to underestimation if there is femoral stenosis by atheroma or atherosclerosis. Okay. Now look at the B, side hole catheter versus end hole catheter. You see, the end hole catheter has led to maybe overestimation, damping. That's why you always, it's preferable to use a side hole catheter because the end hole catheter might lead to damping. Okay. So the message from this slide is that if you, after hemodynamic tracing of the aorta, you should use, for the sake of accuracy, central ascending aorta catheter and side hole catheter. Good. Now, what is this? Show me what's the difference between these two slides, between these two tracing. What's the difference between the fixed obstruction and dynamic obstruction? Mm-hmm.
The fixed obstruction, for example, aortic stenosis, it will not be affected by volume or pressure or anything. Not like the dynamic obstruction, like in HOCM or hypertrophic cardiomyopathy, where it could be changed by other physiological
Very good.
parameter.
Yes, so the dynamic obstruction, dynamicity implies changing level of obstruction that depends on the loading condition, depends on the level of contractility, depends on so many other factors. But as far as this slide is concerned, can you describe the difference?
When we comparing the systolic in the LV and the aorta, in the fixed obstruction, it's more close to each other, the peak. But in the dynamic, in fixed obstruction, there are late peaking of the aorta.
I think the ascending limb of pressure of the aortic during aortic stenosis is getting late. While in the obstruction, from the beginning, there is the high ascending limb of the aortic.
Oh, exactly. So the first thing you have spotted correctly is this delay. There is no delay in the dynamic obstruction, but there is tardus pulse in aortic stenosis when it's fixed. Tardus means late. Yes, this is one thing. What's the second? What else do you have here? Look at the waveform here. How does it look like? It looks like
plateau.
exactly. Not deep and plateau. That's spike and dome.
Spike and dome.
And dome. This is the dome, and this is the spike. Okay, and this is because of what? This is spike and dome. Why do we have spike and dome?
Of the hookah.
High EDP.
High EDP. No. If you consider hookah is not fixed obstruction. Not, it changes according to the loading condition and contractility, and it changes according to the stage of systole itself. So the initial flow might go unimpeded, but the mid and late will be obstructed. Okay? So even if you consider it within the cardiac cycle, within a single cardiac cycle, the obstruction differs. So the initial one goes unimpeded. When it goes unimpeded, what does that mean? The velocity will be high or low? The initial flow goes unimpeded, meaning the velocity is high or low?
Low.
Very good. So when the velocity is low, the pressure is high or low?
Pressure is high. The pressure is high.
The pressure is high.
Yes.
Exactly. Because the pressure and the velocity are inverse.
Yes.
When the velocity is high, the pressure goes low. When the velocity is low, the pressure goes high. Does that make sense? Yes, it makes sense. الآن أنت بس تخيل كده, if you are moving so fast, the pressure you are imposing on the surrounding will be lesser than when you go slow. The slower you go, the more pressure you impose. The faster you go, the lesser pressure you impose. So that's the same here. When the initial flow goes unimpeded, the velocity is high. The velocity is high. The pressure is. The velocity is low.
Low.
The velocity initially the velocity is low, so the pressure is high.
High. Yes.
And late systole, the obstruction is maximum, so the velocity is high. The pressure is low, and that's exactly what we see here, right? This is exactly what we see here. The initial one, the pressure is high, and then the pressure goes low. Initially, pressure is high. Why? Because the velocity is low. Now, the second part of systole, the pressure is low because the velocity is high. What is the equivalent of this one? The dagger-shaped signal of the LVOT, which looks like that, the dagger-shaped signal. It's about velocities. Initial flow is low velocity. The second half of systole is high velocity. So when you take the velocity and you compare it with the pressure, you could come to this inverse proportion between the pressure and the velocity. So you understand this point?
Yes.
Good. So the spike and dome wave form of Hookham. Okay, what do we have here then? This is probably the most famous slide in cardiology, or the most famous invasive hemodynamics in cardiology.
Brackenberg phenomena with aerobics.
Exactly. So can you explain it further?
The BVs. The changes of the volume before and after the BVs.
Okay. Here, the
There is
PVC.
aortic stenosis.
Yeah, but if I ask you a question, the PVC increases the gradient across Hookham or decreases the
In
gradient?
case of aortic stenosis, the aorta in case of aortic stenosis, it decreases of Hookham.
Sorry, what is the question?
I mean, طبعا احنا we are not talking about the PVC itself, we are talking about the post-systolic or post-PVC beat, right? Right? We are talking about yes. So if we talk about the post-PVC beat, what the post-PVC does on the flow?
It will increase the flow because there will be a large volume and it will overcome the pressure better than the other. There will be that's why there will be a big.
Type, stay with me. If we have more flow, the obstruction in Hookham will decrease or increase?
It will decrease.
Decrease.
Thank you. Thank you. Lakin here, the gradient increased here, indicating that the obstruction becoming more. How can you explain that? No, in Hookham increases. You see here in the bottom, the gradient becomes so big deal after the PVC, meaning the obstruction becomes more tighter after the PVC beat. So we have to explain it. لأنه PVC has double effect on the heart. It increases the volume, and the volume will expand the heart. And when you have more volume in the heart, you have less obstruction by Hookham.
Yes.
But it does another thing which is more overriding. Does another thing which is more overriding. And that thing is, you remember Dr. Jamil and the Starling law? The more of the diastolic relaxation, the more the force of contraction. So the beat post-PVC, there is enhanced contractility. Enhanced contractility. Okay? And when you have enhanced contractility, what does that do to the Hookham? Increases the obstruction. So the PVC has something decreasing the obstruction and has something increasing the obstruction. Which factor is going to defeat this battle? The increased contractility is much more than the increasing volume. Yes, that's why the PVC, the beat after the PVC will increase the obstruction in Hookham. It will increase the obstruction. And we see that here by increasing the gradient. Look here, see the gradient, how it is now after the PVC. Compare it to the baseline gradient, which is so modest.
Yes.
Okay.
Yes.
Yes. Exactly.
So
that
this
is
is one
because
thing.
it's decreasing the volume across the aorta. The amount of cardiac output is decreased through the aorta. So the gradient increase.
You mean in Hookham?
Yeah.
But we said that actually the volume increases post-PVC because of longer diastolic relaxation, and because of the Starling law, you have more of a stretch, more of diastolic relaxation, more of volume, therefore there will be more of a stroke volume.
But I mean the net result of that.
Yes. The net result is, yeah, I agree with you, is increased obstruction because of increased contractility, which is more influential than increasing volume.
Yeah, exactly.
So the net result is increased obstruction. The obstruction increases post-PVC. And that's what we see in here. What about fixed stenosis? The same. The fixed stenosis increases the contractility and increases the flow. Here, the increasing gradient in fixed aortic stenosis is influenced by two factors, which are working together. Not like Hookham, they are negating each other. In fixed stenosis, they work collaboratively because increasing volume will increase the gradient across fixed obstruction. Increasing contractility will increase the flow and will increase the degree of stenosis, or I mean the gradient across stenotic aortic valve. And here what we see, the gradient has increased after the PVC. So in both conditions, fixed or dynamic, we could appreciate so well, we have an increase in gradient post-PVC. So what's the difference between the two then? What's the difference between the two?
The dynamic changes in the Hookham and the fixed changes in the aortic stenosis.
معلش come again يا فكري, come again.
Sorry, Abbas, I think you mean the difference between the two, right? The stenosis and the Hookham, right?
Yes, yes.
I said the changes in Hookham usually is dynamics. It could be changed from one beat to other, not like the aortic stenosis where the changes will be fixed.
Okay, good. This is one thing. Like as far as this is concerned now, we have a PVC that led to an elevation in the gradient in fixed stenosis and elevation in the gradient in dynamic stenosis. So how can we make a difference between the two?
So the difference is that in the fixed aortic stenosis, there is increase in the pressure in the aorta and LV at the same time, but still the gradient is it's increasing. In the Hookham, the pressure in the aorta is decreased and the pressure in the LV is increased, so also the gradient is decreased.
Thank you so much. That's exactly what it is. So in fixed aortic stenosis, the aortic pressure is going to increase and the LV pressure is going to increase simultaneously. But the LV pressure probably increases more, that's why you have higher gradient. In Hookham, when the obstruction is so much from the baseline, the aortic pressure tends to drop. And that's why the pulse pressure gets smaller in dynamic obstruction and it remains fixed or even higher in fixed stenosis. And this is what you see exactly here. You see this one here? The pulse pressure. The difference between systole and diastole remains the same or prolonged a little bit in fixed stenosis, but it shortens in Hookham. It shortens in Hookham when compared to the baseline. So this is the only difference between the two, and this is what is called Brocken-Pro sign. This one, the decrease in the pulse pressure, not the increasing gradient after the PVC, because in fixed and dynamic, they all increase. The only difference between fixed and dynamic is the change in pulse pressure. It remains the same in fixed stenosis, it's shortened in Hookham. Okay?
Exactly.
So this is the Brocken-Pro response, which is called Brocken-Pro. What's the full name of this?
Brocken-Pro.
Braunwald something.
Brocken-Pro, Braunwald-Marrow phenomenon.
Yes,
Three cardiologists have described it, but the honor just goes to Brocken-Pro somehow. Okay, so this is the Brocken-Pro sign. Okay, I think we have done this one. Okay, now what do you see here? Show me what you see here. طبعا dobutamine echo has taken over, but they used to use dobutamine invasive hemodynamics to explore the aortic stenosis in cases of dispute about the true severity. And this is usually when you have low ejection fraction, right? So when you have low ejection fraction and you are suspecting severe aortic stenosis, but you fail to elicit a mean gradient of more or equal to 40, you will do the vitamin echo. But they used to do the vitamin cache, okay? And this is the vitamin invasive hemodynamics. Compare the baseline with the vitamin in A patient and in B patient. In A patient, what do we see? After the vitamin, the gradient goes from 28 to 42. And the area from 0.7, it remains 0.7. In patient B, the gradient from 22 goes to 24. The area from 0.7 to 1.2. So, what's your analysis now? Which one has true severe stenosis and which one has pseudo-severe stenosis?
In case of there is true aortic stenosis.
Okay, in A, true aortic stenosis.
Pseudo
okay.
aortic
Exactly.
stenosis.
Exactly. And why you say that?
Because after, in case of patient B, after the vitamin,
the area increased. Exactly.
Yes.
Exactly.
But
Yes.
in case of patient A, the area is fixed in spite of the vitamin.
Very good.
So patient A has true aortic stenosis, and patient B has pseudo aortic stenosis.
Exactly. And this is exactly what we are looking for in the vitamin echo. We are trying to elicit the same data. We are giving the vitamin in incremental doses by infusion, and we are checking the gradient and the area. True severe aortic stenosis is defined as we get a contractile reserve of more than 20%, the gradient goes high to 40 mean, and the area remains the same. Okay? If the gradient goes high, but the area opens up, meaning that it wasn't true stenosis. The problem is we have a third scenario, and that scenario is I might fail to increase the gradient and everything remains the same. This is called absence of contractile reserve, meaning the vitamin has done nothing to push the heart into contractility. So things remain the same. In this case, you are stuck. You cannot conclude about severity of aortic stenosis. Okay? So you get this point here, everybody? This is important. So everybody understands?
Excuse me, Doctor.
Sure.
Can you explain it again?
Okay. We give the vitamin, okay? The vitamin is given in infusion. We start by 5, 10, 15, 20. We don't exceed 20, okay?
Yes, the maximum dose 20.
20. That's why it's called low dose the vitamin. It's not like the vitamin used for ischemia, you go up to 40. But here, up to 20. Our purpose is what? Is to enhance the contractility.
Yes.
Okay? Because we are assuming
low flow due to loss of contractility.
Yeah, low flow, low ejection fraction.
Yes.
This is the patient we should check for the vitamin. Which patient are we going to check for the vitamin? The patient in whom we are suspecting the aortic stenosis to be severe based on morphological data, but the gradient is lower than 40 and the ejection fraction is lower than 50.
Yes.
Okay? So we give the vitamin, assuming that the vitamin is going to enhance the contractility and that's going to enhance the flow and that's going to increase the gradient. So if we are dealing with true aortic stenosis, what are we going to get? We're going to get more gradient and the area will remain small, below 1. If we are dealing with pseudo severe, it's not really severe. It was just because of the low flow. The aortic valve does not open well, but the area has potential to open up. When you give the vitamin, you enhance the contractility, the flow goes robustly across the valve, it opens the area up. So we might have an increasing gradient, but we also have increase in area.
In the area size.
The area is no longer less than 1. It opens up, meaning there was no true aortic stenosis. We are just deceived by the low cardiac output to assume that the area is tight. Okay?
Yes, yes, yes. Yes.
So this is the difference between the two.
Okay, thank you.
Excuse me, Dr. Hatim.
Sure. Yes.
But I'm asking about the shape of tracing of the ventricular after dobutamine in case 1. The shape of the wave.
Okay. Of the LV, you mean the LV wave?
Yeah.
The LV wave, yeah, it changes because there is increased contractility. And when you have increased contractility, the pressure goes up. Okay? Contractility means more flow means more pressure. It's only the increase in contractility. So now if you count the contractile reserve, it should be more than 20%.
لا أنا I mean إنه why إنه the shape of LV wave is different from case A and B.
Don't worry about this. I agree with you. There is a lot of artifactual problem with the waveform. They are. I see the dichrotic knots was so prominent in dobutamine rather than in the baseline. Yeah, but that's just artifact because you know the catheter position and being side hole or end hole has a lot to do with the crisp signal of the hemodynamics. It has a lot to do. Okay. That's why we have a lot of artifacts, by the way, in the invasive hemodynamics, and you have to make sure that you are obtaining it right, and you are using the right catheter, and you are positioning fixed in the place, and all of that. Okay. But this is good observation. Thank you so much. Okay, now this is a bit tough, but I think you can get it. What do you think about this patient at baseline? Is gradient 32, and aortic valve area is 0.9. He was given nitroprusside, which is vasodilator, and his gradient now is 45. Aortic valve area is 0.9. What is this? So what do you think about this? Think of it. Can give you 30 seconds. Think about it.
This patient may have a co-location of the aorta.
Really?
Maybe.
Good attempt. And it's always appreciable when you just speak your mind out. This is so encouraged, actually. And I want you all just not to shy away from speaking out your mind. Okay. Look at it again. I might make it easier for you. If you look at the baseline, we have a gradient that is not high. It's only 32. The area is 0.9. But when we gave nitroprusside, which is a vasodilator, we uncover or unmask or disclose the true gradient, which is 45. So we have an aortic stenosis, which was underestimated, but we came to the right picture after we gave nitroprusside. This is brand new. So what do you think about it?
Aortic membrane or hook'em?
No.
This is
This
The
is
outcome.
supra aortic. Because
No,
after
uh-huh.
because the
in case of the baseline, maybe the ejection fraction of the in case of baseline, the ejection fraction was low.
Uh-huh. Okay.
And the night and
Good.
after
Okay,
we
I
give the
appreciate.
nitric
Nitroproside.
oxide, we decrease the afterload.
Uh-huh.
We decrease the afterload.
Very good. Uh-huh.
So the gradient increase.
Okay. Very good. Great guess. Decreasing afterload has resulted in increased gradient. How come?
it is increased gradient, but it decrease the pressure in the LV and
Exactly. Yes, we know that because nitroprusside is antihypertensive, so the systolic pressure of the LV and the aorta has decreased. But we disclose a higher gradient across the aortic valve. So now we come to the true gradient of aortic valve, which was masked at the baseline when the blood pressure was high. So what does the blood pressure do to the evaluation of aortic stenosis? This is a very hot area in cardiology nowadays. Hypertension and aortic stenosis. And if you allow me just to explain it briefly, because it's very complex, okay? In the new guidelines issued in 2020, probably for the first time to the best of my knowledge, they mentioned blood pressure in the evaluation of aortic stenosis. They mentioned to control the blood pressure well enough before you evaluate aortic stenosis. So the blood pressure has a lot to do with the diagnostics of the aortic stenosis and with the prognostics of the aortic stenosis. Let's start with the prognostication. If you have a combined aortic stenosis and hypertension, you think this is bad or good?
What is bad?
This is bad.
It is bad.
High peripheral vascular resistance
Exactly.
with a small area of aortic stenosis.
Yes. So
An
this is bad.
underestimated area.
Before the underestimation, let me talk about the diagnostication and diagnostic later on. Now we are talking about the clinical impact of having aortic stenosis and hypertension together. That will accelerate the hypertrophy and the RV failure and the remodeling. So when you have double whammy, they call it double whammy because now the heart is influenced by two tough factors. The aortic stenosis on one side and the hypertension from the other side, both of which are impacting the RV and the LV strongly. So these patients are earlier to get into symptoms, are earlier to lose their LV. They will have more LVH. Okay? So if you remove hypertension from the equation, patient will do better. You will delay the onset of symptoms. You will retard the progression of the LVH and the LV dysfunction. That's why it's so essential to treat hypertension more robustly when you are dealing with aortic stenosis. Okay? Now they call it the impedance, ZVA, ZVA. Z stands for impedance, VA, valvulo-arterial impedance. So the LV is influenced by the valvulo-arterial impedance, valvulo from aortic stenosis and arterial from the hypertension. And there is a way by echo, we count the ZVA, the impedance ZVA of the valvulo-arterial. Okay? So it's important we treat hypertension. This is from clinical perspective. Now from diagnostic, do you think having high blood pressure and you are evaluating a patient for aortic stenosis, is that gonna underestimate or overestimate aortic stenosis?
Underestimate.
Why?
The velocity have a resistance in the peripheral vascular. In hypertension, there is a resistance. So the velocity will be slow through going through the aortic stenosis.
Okay, why?
The
Why it will
gradient
be
will
so?
decrease.
The gradient will decrease. Okay. So we know that.
He actually it decreased.
Huh? Sorry, I lost your voice. I think I lost your voice.
In case tension,
Unfortunately, we don't hear you. Do you يا اخوانا؟ الصوت أظن مشكلة.
in case of aortic
of aortic stenosis,
yes.
Okay.
In case of aortic stenosis and hypertension, the velocity is low, is high, and the gradient
is low. Is low. Yeah, I get your point. Good. This is good explanation, good analysis. Yeah, I will make it easier for you to understand. Now, if we have high blood pressure, what does that do to the LVH? Will increase, right?
Yes, will increase.
Right. If you have high blood pressure, what does that do to the diastolic function?
Impair.
Impair. Very good. So if I have more of LVH, more impairment of diastolic function, how about the flow across the aortic valve? Will go low, right?
Yes.
Will be low. Yeah, will be low. Exactly. Will be low. Though the ejection fraction and the amount of contractility is seemingly normal, but the heart is effectively not pushing enough blood out. That's why I have low flow. That's why I have low gradient. Though I have normal ejection fraction because of the diastolic problem and because of the LVH. So when you have hypertension, that will impact the function of the contractility will be functioning apparently normally, but the actual stroke volume drops. And this will decrease the gradient. And that's why when you treat hypertension, the LV function, diastolic LV function will improve and the gradient might increase, like in this case. So after giving nitroprusside, we remove the high blood pressure, we enhance the flow across the LV because we improve the relaxation, and that leads to increase the gradient. So the hypertension underestimates the gradient. Okay, you get this point?
Yes, clear.
That's why in the new guideline they mention you treat hypertension for two reasons: for clinical reasons, because we have explained that, and for diagnostic reasons, because if you have high blood pressure, you might miss severe aortic stenosis. Okay, that's why you treat it well adequately before you evaluate aortic stenosis. Okay, good. Now, what is this? I promised to show you the difference between the wedge and the LA pressure tracing. And here is the difference. Look at this slide and tell me what you see. If you look at the wedge, you look at the left tracing, there is high gradient of 15. For the same patient, when they used LA pressure tracing, the mean gradient is only 6.
Yes.
Why is this difference?
We said that there is a false estimation due to septal penetration in the accurate measuring of the LA pressure.
Which one is more accurate?
LA pressure.
Thank you.
Yes.
Okay. Now, if you look here, I will show you something very interesting because this is not uncommon. Look at the gradient here and here. They are the same, right? They are the same. The wedge pressure.
The wedge become less.
But the difference is in timing.
Yes, in the wedge is less.
Exactly. Look at this one. What is this? This is A. And what is this? This is V. V means systolic wave. The systolic wave should follow the LV and goes down with the LV, like here. But follow this V wave. It is late. It's late. You know, it's late because the wedge is late.
Yes.
And that's why there is a false sense of, I have a gradient here, which is not the actual gradient. It's just created erroneously because of this visual illusion. If you push the wedge back into the right place, you will eliminate that gradient.
The gradient is
so the wedge will overestimate the gradient erroneously because of this time delay if you are not careful enough to adjust for the time delay. Okay? So this is important. I wish you get this point clear. Good. Okay, now look at this patient. Okay, again, Nishimura. Patient A at rest and at exercise. I will zoom in, rest and exercise for the first patient. What do you see here? Sorry?
The gradient become more with exercise.
Exactly. So this is a symptomatic patient in whom they fail to elicit high gradient across the mitral valve in rest echo. So they resorted to do exercise, and they did exercise in the cath lab. Do you wonder how? How did they do exercise in the cath lab? How do they do exercise in the cath lab?
Chemical?
Not chemical, that was exercise, physical exercise.
Okay, by hand fisting and upper.
Hand fisting may be okay, but there is a better way, which is
Falsafal maneuver?
No. Bicycle ergometer. Bicycle, a bike. Okay, so
as if we're inside.
Yes, exactly. It's a bicycle. So his limbs are busy doing the exercise, but the upper torso is fine and there is no motion, so you can do your cath without problem. Okay, so this is the only way you can do exercise echo in the cath lab. I mean exercise test in the cath lab. So they did the exercise test, and what they get is the capillary wedge went up to 41 from 18, and the mean gradient shot up to 29 from 8. So what's your final analysis? What is your final analysis here?
Stenosis.
Exactly. That
Severe
is
mitral stenosis.
Mitral stenosis. Now, I am going to ask you a question. This patient was symptomatic, and at baseline, we failed to elicit data to support severe, but at exercise, hemodynamics are clearly in keeping with severe mitral stenosis? What are you gonna do to this patient in terms of management?
It needs intervention. It depends on the valve assessment, maybe BTMT or cervical.
So now the patient qualifies for intervention. This is class what indication? Is it you should, well, it is reasonable and maybe reasonable?
You should.
You should.
Class 1 symptoms.
Okay, so we all agree that is class 1 indication?
Yes.
Yes.
Unfortunately, it's not. In the guidelines and in the new guidelines, I was so hopeful it become class 1 indication, but it still is class 2. And I don't remember if it's class 2A or B. I think it's even B. But I don't know why. You know, you elicit severe obstruction across the mitral valve during exercise, but that will not make it should intervene. That's the problem in the guidelines. All exercise-based hemodynamics, if they elicit severe in aortic stenosis or mitral stenosis, the patient will not qualify for intervention or surgery as class 1 indication. It will be class 2. The only class 1 indication yet in the guideline are only 3 symptoms: LV dysfunction and going for other cardiac state. Only these 3. So if you elicit severe valve stenosis during exercise, unfortunately, that will not qualify as class 1 indication. And I personally don't know why, but this is the guideline. Right. Let's see the other patient at rest and at exercise. At rest, you see that wedge is normal. At exercise, or not normal, it's 13, yani it might be a bit high or normal, I would say normal. But at exercise, it's 41. What's the problem in this patient? What is the problem in this patient?
Severe diastolic dysfunction.
Thank you so much. Because there's no MS here. There is no MS. So the only explanation I would jump into is the diastolic dysfunction. The diastolic dysfunction. Well done. Now, what is this? Diastolic dysfunction uncovered during exercise and was masked during rest. A patient who has symptoms of heart failure, his echo is normal, his E over E prime is normal. There is no hemodynamic data during rest to suggest diastolic dysfunction. But clinically, he has HFpEF. What are you going to do? Usually, what are we going to do? Usually, we send the patient to medicine to take care of this patient, and we sign off, right? We sign out. But now, since 2016, in the guidelines, let me just note. Okay. So in the new guide, not new guideline, from 2016, they have spoken about the diastolic reserve testing.
Reserve.
And diastolic stress test. This is diastolic stress test. You can do it by echo, which is the trend, and this is the actual standard, is echo based. But this is done by cath. Okay? And you see the change in the wedge from 13 to 41, indicating an occult severe LV diastolic dysfunction. So now we know this patient is HFpEF, though from the rest data, we failed to diagnose HFpEF. That's why it's important, if you have high clinical suspicion of HFpEF, not to stop at rest echo and you need to do stress echo or diastolic stress to evaluate for the diastolic reserve. Okay, good. Now, what it
I
is?
know most of these patients, they come already, they are complaining of exercise intolerance mainly. There is no symptom of congestion or heart failure, other sign.
Exactly. So it makes sense that you exercise them because their symptoms are exercise intolerance. So it makes a lot of sense that when we exercise them, we might get into the true hemodynamics. Okay. The second most common slide in cardiology exams after the broken bro sign is this one. The difference between constriction and restriction. So what's the difference here? What is the difference?
In the left, there is discordance.
There is?
The LV and the RV.
Very good.
And it is constricted pericarditis.
Very good. So on the left is what? Constriction or restriction?
Constricted.
Constriction. The second one is constriction. Why? Why it's constriction?
Because there is discordance between the LV and the RV in inspiration and expiration.
Very good.
In expiration.
Very good. Very good. And if I take just two samples, when the LV goes low, the RV goes high, and vice versa. That is discordance. LV, RV, discordance. This is constriction. Look at the left slide. Goes up, goes up, it goes up. Go down, it goes down. This is concordance. Concordance. Okay? LV, RV, concordance. Concordance is restriction. Discordance is constriction. Good. Why? The question is why constriction leads to this discordance? Why? Why constriction leads to this discordance? How can you explain the physiology behind this?
Because in case of inspiration, there is increased blood flow to the right side of the heart.
Okay.
And decrease pressure in the pulmonary.
Okay.
In the same time, there is decreased pressure in the left side.
Okay. Yes. So, yeah, if I ask you a question, you think the discordance is all pathological or it's about the degree? I mean,
about the degree, it can happen physiologically.
Very good. Very good. And that's why in constriction, we don't say that we have discordance. We say that we have increased interventricular interdependence or enhanced interventricular interdependence. But the interventricular interdependence is physiological. But when it exceeds some degree, it indicates constriction. Okay? So it's a matter of the quantity, not the quality. That's important. So during inspiration, more blood comes to the right side and less blood comes to the left side. You agree or disagree?
Yes.
Do you agree? You agree,
yes.
right? That's why there is discordance. That's why there is discordance, and this is physiological. Right. My question is, why do we have less blood coming to the left side during inspiration?
Because there is a stiff pericardium.
I mean, physiologically, just in the physiological conditions, we still have less blood coming to the left side of the heart during inspiration. Why?
Because the pulmonary vein is intrathoracic. And there is decreasing pressure in all intrathoracic.
Okay.
So decreased flow in the pulmonary vein. And IVC and SVC is out thoracic, the flow is the same.
Very good. Good. When you have inspiration, the lungs will expand and the blood will be pulled into the lungs. So the flow to the left side of the heart will go low. زي ما الدكتورة قالت البلمونري vein are intra pericardial and the venous right venous system is extra pericardial. لكن أهم نقطة إنه during inspiration the blood pools or is imprisoned more in the lungs than it goes to the left side of the heart. And during expiration, the lungs shrinks against the circulation, so there is more push of blood to the left side. Okay? Now, the low flow of the blood during inspiration to the left side of the heart will decrease the LA pressure because you have less blood. That's why the LA pressure goes low. But the LV pressure goes also low during inspiration. That's why it maintains the gradient a little bit normal during inspiration, expiration with just tiny, modest variation. Why is that? The LV during inspiration obeys the intrathoracic pressure. It obeys the intrathoracic pressure. So during inspiration, the intrathoracic pressure drops, the LV pressure drops. And the gradient, though we have lesser LA pressure, but we also have lesser LV pressure, and the flow goes nearly as normal as in inspiration, as expiration. But if I have constriction, what do I have? I have a low flow coming to the left side, to the left atrium during inspiration. Because of the inspiration, we have explained why. But now the LV is no longer connected to the intrathoracic pressure and no longer obeying the intrathoracic pressure swings because it becomes isolated by the top pericardium. So it will remain high and will not relax and the pressure will not drop. So that will lead to a drop in the gradient between the LA and LV. And that's why I have less flow to the left side of the heart. This is one side of the story. The other side of the story is when I have constriction, the heart is limited to expand laterally. So it depends on the septum. So the septum will go left and right so much, you know, the septal bounce, it goes. So during inspiration, the septum is shifted leftward so much, and that will minimize the LV cavity, and that will increase the pressure, and that will decrease the gradient between the LA and LV, and that will decrease the blood flow into the LV. So we have two reasons of why the pressure drops in the LV in inspiration in constriction. It's because of two sides of the story, the septum and the pulmonary circulation, and the failure of the LV to relax obeying the intrathoracic pressures. I'm so sorry if it's complex, but you will, if you just sit back and relax by yourself and think of it again, I think you will figure it out. But remember, in constriction, we have exaggerated interventricular independence leading to this disorder. Okay? What else do I see here in constriction? What is the other invasive hemodynamic data you collect from this signal and it's in keeping with constriction, apart from the discordance? And it is here. It is here. This one. What is this?
Deep and plateau.
Exactly, the dip and plateau of the diastolic curves, or the square root sign, because it looks like square root. So this is the dip and plateau. Why it's dip and plateau? The normal looks like you go this way and like this way. Okay, that's the normal. But the dip and plateau, it goes so low and then suddenly it rises so much. Okay, why is that? Why is that?
Because of the stiff
Mm-hmm.
LV.
It's stiff ventricle, yes. Okay, so if you have a stiff ventricle, meaning what? The LA pressure is high because the diastolic dysfunction is here, is like grade 3 and 4. You remember in grade 3 and 4 diastolic dysfunction how it looks like? It looks like that by echo. High E and small a. High E and this is E and this is A. This one is what? This one. This one is this one. Okay? And it ends suddenly. That's why it ends suddenly here. It's short because it goes this way and suddenly equalizes. Okay? So this is an indication of grade 3 for diastolic dysfunction. Okay? Good. Now let's move on. Okay, I will skip this one. Look at this one here and tell me what you see. I think this is the depiction of the normal JVP. JVP, E, T, X, V, and Y. Okay? Right? We all know A is for atrial contraction, and V for systole, and X for what, and Y for what? Let's find out. Okay, so this is the A wave, the X descend, the V and the Y descend. So the A is atrial contraction, and the X is what? What is X?
Tricuspid closure.
Exactly. So the tricuspid valve closes and systole started. So during this time, the atrium is relaxing. That's why the pressure is dropping. Except for a tiny wave of C that might interrupt this relaxation. And this C is what?
Upgoing of the valve.
Thank you, because after the closure of the tricuspid valve and during systole, the annulus might push a little bit upward, minimizing the RA cavity and increasing the pressure momentarily. So C is due to the ascend of the tricuspid valve annulus. Now we have V. What V means? V means venous return to the right atrium. The venous return. That's why the atrium now is filling with blood. That's why the pressure goes up. After it's full of blood, it opens passively. That's the Y descent. This is the initial flow before the atrial contraction. So the Y descent is the E wave in echo. Okay? Good. Now you understand. Now tell me here, what is this? The normal jugular pressure looks like that. Look at here. Severe tricuspid regurg. What do you see?
Prominent V wave.
Exactly. And what else? Prominent, and we lost what? We lost the
X.
X descent. Exactly. What do we lost the X descent? X descend is what? X descend we said after closure. Exactly. The left right atrium is supposed to be relaxing and the pressure is dropping. But now blood is coming so swiftly and strongly into the right atrium because of severe TR. So the pressure will not relax. And that's why we have a sudden jump from A to V. Sometimes they call it CV wave, CV, because from where C is supposed to be, it goes up suddenly, CV wave. Okay, so this is severe tricuspid regurgitation. Now, look at this one here. In constrictive pericarditis, what do we have?
Prominent X wave.
And look at the Y. Look at the Y.
Small
here.
a.
Look at the Y in the normal tracing and compare it with the Y in the constriction.
Decrease.
Also
Decreasing
prominent.
Or increase. Prominent, exactly. If you compare the up with the down, the normal with the constriction, the Y descent is blunted in the normal, but it's so steep in constriction. This is called the precordial knock. Sometimes by clinical exam, you can appreciate a hair card sound. Knock. Yes, that's the knock. Okay. Now, look at this one here. Tricuspid stenosis. Explain why tricuspid stenosis led to this. Explain.
Here, there is a prominent A wave.
Exactly. That's prominent A wave because of tricuspid stenosis. If you have tricuspid stenosis and the atrium is contracting, you will have this high A wave, and this is axiomatic, commonsensical. Okay, complete heart block. What do we see here?
Prominent
A wave.
Prominent A wave.
Canon
But
A
here
wave.
it's not. Thank you so much. It's not prominent A wave because the initial part of the tracing.
Yes, Jayan. Yes.
Exactly. This is canon A waves. Okay, can you explain more? Why do we see canon A wave in complete heart block?
Because of this contraction of atria against close.
Very good. Yes, this is the highest pressure A wave to the chest. Yes, when the atrium contracts against a closed valve, the pressure will tremendously go high. And that will be intermittent because this deassociation is intermittent, it's not fixed because of the complete heart block. So canon waves are very high A pressures and intermittent. Good. Now what we see here, precardial tamponade. What do we have in tamponade? Deep X descent. Deep X. So deep Y in constriction, deep X in tamponade. SD. What do we have here?
Blunted.
Blunted
Y
we
wave.
Have blunted Y and X. Okay. Like if you compare it with the normal, look here at the normal and see, tell me about the A. You think the A is prominent? You think the V is prominent? Which one is prominent? A and V.
Both.
A and C.
V. Why? Yes. Why do I have prominent V wave? Why do I have prominent V wave?
Left to right.
Exactly. V wave is what? We said V wave is venous retained. Venous retained. Okay.
RV filling.
Exactly.
RA filling.
Yes.
The blood
so
flow
when you have
height and increase the venous pulmonary blood flow.
Yes, because V stands for venous flow or venous retain through the IVC, SVC, and any other source. What are the other sources which are pathological? The TR and ASD. The ASD will bring more flow into the left atrium, into the right atrium. That's why we have prominent V. The TR will bring a lot of flow. That's why we have very prominent V. So remember, the venous retain is through the IVC, the caval flow, but it might be through ASD and through TR. Okay. Now let's move on this one. Okay. Do you remember we have talked about the
Yes.
increase in blood pressure as you go down? This is called peripheral augmentation phenomenon. Peripheral augmentation phenomenon, meaning that the further you go from the central aorta, the more the blood pressure. And that's because of reflected wave. الفسيولوجي حقها الcolumn of blood ده as it goes down بيعمل reflection للwave. And this reflection of wave will build like دوامة كده. It will build as you go down. And that will increase the pressure as you go down. Peripheral augmentation. يعني if you see here, normal artery and arterial stiffness, when you have an elderly patient with arterial stiffness, what do we usually have? We have very high systole and low diastole. The pulse pressure is high. Why do we have this high systolic pressure? Because of blood pressure in this patient, which is quite likely given his age, and because of the peripheral augmentation. Because if the artery is not recoiling, is not elastic enough, the peripheral augmentation will be higher. Okay? Because the reflected wave that builds down the stream will be more and stronger. Okay? And if you look here, if you follow the arterial pressure from the aorta, brachial, radial, femoral, dorsalis pedis, you could appreciate two phenomena: the divergence between the systolic and diastolic. So the diastolic blood pressure keeps going up, and the diastolic blood pressure keeps going down. This is physiological, but it's more enhanced in elderly who have stiff arteries. Okay? That's the peripheral augmentation of the systolic pressure. Okay. Now look at these characteristic arterial waveform. When you have aortic stenosis, we said we have pulsus, tardus, pulsus. So the pulse is small and delayed. Now when we have aortic regurgitation, what do we have? Aortic regurg.
Wide pulse pressure.
What pulse pressure and what else? You see this one here?
Collapsing pulse.
Two waves. Collapsing pulse is because of this high flow. Yes, that's clinically. But what do we see in the waveform here? Double wave, right? Right? Bifid pulse,
Yes.
right? Why is that? Why is that? Because the valve is supposed to close here. This is the dichrotic notch. It's supposed to close up here, but because of the reflected wave in the aorta, it goes back and it builds on the pressure, which was tending to decrease. It was physiologically tending to decrease like this one, but because of the backflow from the AR, it goes up again. Okay? So that's why you have bifid waveform. Now, when you have low stroke volume, the pulse will be slim like this, and the dichrotic notch will sit low. When you have high cardiac output or stroke volume, the dichrotic notch will go high, and the pulse will be stout. Okay? Good. So these are important things about the waveforms, important in the management of patients. What is this? What do you see this here?
Pulsus alternus.
Pulsus alternus. What does that indicate?
Severe LV dysfunction.
Thank you so much. Severe LV dysfunction. Thank you so much. Does it have anything to do with electrical alternance?
No.
No, thank you so much. That's an ECG and that's pulse. مع انه دائما الناس بتلخبط فيهم لخبطه لا يمكن تتخيلوا نطاقها قد ايه كده. الناس دائما they are confused about the two. They are quite separate by the way, okay? يعني electrical alternance will not generate pulsus alternance. مع انه sometimes it's kind of commonsensical if I have an ECG with beat to beat variation in the ECG معناتها الpulse might be beat to beat variation. No at all. That's an electrical activity that is picked by the ECG to you to precardial effusion and swinging of the heart closer and away from the chest. And this is because of severe LV dysfunction. Okay. Now, what is this? Up is the pulsus alternans. Compare it with the pulsus paradoxus and tell me the difference. What's the difference?
Pulsus alternans nothing to do with the respiration.
Very good. Very good.
Pulsus paradoxus is decreased during inspiration.
Very nice. Yes. So this is beat to beat variation and this is respirophasic variation. During inspiration goes low, but this is beat to beat. And during inspiration it goes low because in tamponade, during inspiration, you know, the septum goes left and all the physiology that we explain with constriction applies here. And you have decrease in the systolic pressure during inspiration, pulsus paradoxus, which indicates tamponade physiology. Okay. Now, what is this? Pulsus paradoxus. Sorry, pulsus alternus. This is again pulsus alternus. What is this? RA pressure. What's your diagnosis? Why the RA pressure is so high like that? And what is this high wave? Of course, you could not appreciate the A, X, and Y and all of that. But we are appreciating only one wave, which is V. V is so high.
Anomaly.
Yeah, because of what? Because of TR. This is severe TR. Okay, severe TR. Because we have said that severe TR makes the V wave high. Okay. Good. So this is tricuspid regurgitation leading to a giant V wave. Sometimes they call it ventricularization of the V wave because it's close to the RV. It's close to the RV. So it's kind of ventricularized. Okay. So this is severe tricuspid regurgitation. Okay. Now what is this here? LV and wedge. LV and wedge. What do you see here? Don't tell me I have mitral stenosis because there is no mitral stenosis.
High V wave with respirator. So
Exactly. This is LV and pulmonary capillary wedge. So this is mitral regurgitation.
Mitral regurgitation.
Mitral. And look at this gradient here. This is false gradient created by the time delay. So let's do it in our mind now. Shift the wedge back to where it should. It should be here. If you shift it back to where it is, the gradient will go away. So we don't have a true gradient. It's just a visual illusion because of time delay. Here we just have severe MR leading to ventricularization of the V wave. Good. I'll skip this one. What is this?
Yeah, boss, why not not in the last picture? Why not إحنا ممكن نقول there is high LA pressure due to severe diastolic dysfunction?
Of course we do. Of course we do. And if I take this one here, this one, the LV pressure, this is the end diastolic pressure. If you take it here, I think it will be 20 plus. So I have high LV EDP because of severe MR. Yeah, I agree with you.
Okay, thank you.
What is this? Look at this catheter. We have a single catheter and we are pulling back.
Pull out.
It wasn't pull back. It was in the LV, then we are in the LVOT, then we are in the aorta. What happens? There is a gradient. Where is
The
this gradient?
level of LVOT.
Very good. So the very first thing you should observe when you are pulling back and there is a gradient, where this gradient is between. Now we have LV gradient, LV between the LV and the LVOT. So that is a subaortic membrane or hook'em, right? Subaortic membrane or hook'em. If I ask you a question, which one you are more inclined to select from these two? Hook'em or subaortic membrane? And why? It is hook'em.
Subaortic
and why?
membrane.
Hook'em.
The
why?
presence of P-pump?
P-pump, no, not because of that, because of this one here. Spike and dome. See the spike and dome? The spike and dome is very characteristic of hook'em. It doesn't happen with fixed obstruction. And I showed you the difference between fixed and dynamic obstruction. In the second slide, if you remember, we said that Stardust, parvus, and stuff like that, but this is a spike and dome. You see here the spike and dome. So spike and dome will never happen مع fixed obstruction. It's only with dynamic obstruction of hook'em. So this is more of hook'em than fixed obstruction. Okay, good. Now what is this? What is this? Again, this is pull back.
Excuse me, Abbas. Why we have spike and dome in case of hook'em?
Yes. أظن ما حضرتي معانا من الأول صح؟ You missed the first part.
لا حضرت لكن ما فهمت هذا.
أيوة, we explained إنه yes, of course, sure. In patient لما يكون عندك hook'em, what happens in hook'em? The fixed obstruction means what? Means the velocity across the aortic valve will be uniformly high across the entire systolic period. All the systolic period, the velocity is high because it's fixed obstruction. Now, dynamic obstruction, the velocity changes across systole. So in the initial part of systole, the velocity is slow, then it goes fast in mid and late systole. That's why it generates the dagger-shaped signal. Okay? While in fixed aortic stenosis, the velocity is fixed across the entire systolic period like this. What does this do when it comes to the pressure? The initial velocity will generate high pressure. And this one, this part of high velocity, the pressure will be low. So I have initial flow, which is high pressure, and a second flow of low pressure. That's why I have this spike indicating high pressure and dome indicating low pressure because of changing velocities from mid to late systole, from early, mid to late systole, and that does not happen with fixed obstruction because the velocity is fixed throughout the systolic period. Okay? Good? I wish I explained it simply. Am I?
Yes.
Good. Last slide. Thank you. Thank you. Now, what is this? Well, you did not tell me about this one. What's the diagnosis here? We said we have LV gradient is kind of normal, but between aorta and aorta, there is a gradient. So this is aorto-aortic gradient. That is what?
Coarctation.
Coarctation. Exactly. And what is this? This is LV gradient. So this is either subaortic membrane or puka. Last, look at this one here. This is mitral stenosis, the one on the left and the one on the right. The one on the left is mitral stenosis before ballooning, and the one on the right after ballooning. And you see the difference in the gradient, right? You see the difference in the gradient? Yes.
Yes.
Here is the difference in the gradient. This is the gradient. And now you see the gradient has actually disappeared. Look. Yeah. Now, see here, the V wave has increased a little bit. Right? Why is that?
Yes. Because of
Why?
MR.
Yes,
MR.
most likely, exactly. Most likely, they have induced MR. That's good. So I think we finished now. And sorry, thank you so much. This is introduction to hemodynamics. I know it might be tedious and boring sometimes. As I told you, Awad will just do us a session soon on the same subject. So if you miss anything, you can catch up with him. And this recording will be in the SCOM on YouTube channel. So thank you so much.
Thank you for you, sir, really, and you make it more interesting as usual.